So on behalf of the Victorian Virtual Specialist Consults, really grateful to have everyone here, and especially to Dr. Nikki Chambers and to Helen Demetriou, sorry if I pronounced your name wrong there, Helen, talking to us about mastering menopause. So this this online web, oh, sorry, I'll just make sure I've got everyone on mute in the background. So for the online workshop this evening, go for around about 45 minutes to an hour, and there'll be lots of time for questions throughout. I'll leave it up to the presenters if they're happy to take questions during or preferably at the end. And the VVSC is a service which, through the public system, specifically through Northern Health, offers online case conferencing and co-consults where we're trying to bring together GPs from across Victoria to meet with hospital teams and our allied health team as well, if that would be helpful, to co-manage patients with the aim really to keep patients in the community and to support the capacity of primary care and build those connections. And this is also a CGP accredited CPD activity. So at the end, there'll be a quick survey just to put your information in, and we can get the certificate out to you, and I'll send it off to the college. If I could go to the next slide, please. So I know that people may be joining us from all over Victoria, potentially outside of Victoria as well. And so we'd like to acknowledge the traditional custodians of the land on which you're all on. Our health service is on those of the Tongarong and Wurundjeri people, and we acknowledge their continuing connection to the land, waters and community, and to pay our respects to the people and the cultures and the elders past and present, and anyone here is First Nations today as well. Next slide, please. The specialist clinics that are available have expanded, and we'd be very keen to obviously get any feedback or questions around if there's others that you would find helpful in your clinical practice, or if there are ones which are already there which are, could deal with some more availability, or ones which you just have some feedback on. Feel free at your own time to have a look at the VVSC website, VVFC. You can just put it into Google and it'll come up, and they'll be able to walk you through the booking process and all the clinic availabilities. You know, sometimes you can get seen within a week or so, and that can be very helpful, especially for patients who may be in, say, that CAP 3 or CAP 2 waiting list at the public hospital group, where they've got a 12-month wait. You might be able to see them or get them seen within a few weeks, and it's that collaborative consult, I think, which leads to the best outcomes. Enough about the VVSC. We'll hand over to our wonderful presenters, and thank you very much, both of you, for your time today. And over to you.
Thank you, Morgan. So I'm Nikki Chambers, and myself and Helen are going to be here this evening. Helen's going to be in the background answering any questions in the chat. So if you've got any interesting cases, any conversation or input that comes up through the talk, then feel free. It always makes for an interesting discussion. So hopefully, let me just move on. There we go. So this is obviously a sort of overview of menopause. Often there's a sort of wide variety of what people are comfortable with. GP is such a huge area, and we're all confident in different areas of that. So hopefully we'll be able to run through some of the basics and also some of those sort of trickier patients that we get, certainly in that kind of area where there's quite a lot of misinformation and lots of information out there for sort of medics and practitioners, and also the patients themselves. So we're going to go through some cases, and we're going to sort of bring these women and try and bring these women through the presentation, because these are women that we're hopefully typically seeing in primary care, and also Helen and I are seeing in the VVSC clinic. And I'll talk a bit more about the VVSC clinic and how that works and operates towards the end. So first of all, we've got Alison. She's 46. She's pretty fit and active. She's a professional, she's well informed, and she's sort of read up and spoken to her friends who are also going through sort of what they think is perimenopause. She sort of recounts sort of 6 to 9 months of worsening anxiety. She describes it as an irritability, which is really quite new to her. She's not someone that's had mental health problems before. Insomnia. She actually denies hot flushes if you ask her directly if she's having hot flushes. But when you probe her a bit more, she says, oh, actually, yeah, I'm awake every night at the same time. I'm throwing the bedclothes off. And it sort of just makes you think, maybe you are a little bit hot at night. One of her bigger problems or bigger issues is her musculoskeletal issues. So she's been seeing a physio for shoulder pain, and she's had some low backache that's sort of been fleeting and coming and going. Her periods are stretching out, so they're now, she sort of says, last one was 4 months ago, but they're generally fairly manageable. She's quite concerned because she's got a family history of breast cancer. So her mother and sister had breast cancer, and she recently had a mammogram done, and she was BI-RADS density C. So we'll come back to Alison. And our next lady is Olivia, who sort of comes in and she says, I think I'm perimenopausal and I'd like some hormone tests, please. She's 41 and she is quite active on social media. She follows some quite prominent doctors in the US and the UK, and she describes particularly worsening mood. And when we sort of probe her on this, she can really pinpoint it to before her period. And when her period arrives, she feels better. She feels like something's lifted. So migraines as well have been sort of creeping back in, something she hasn't had since she was quite young. She was on the pill, didn't like it, felt that it worsened her mood. She took Levlin when she was in her 20s. Her periods are still regular, maybe a day or two, but generally regular every 28 to 30 days. She's not got any hot flushes. She's no night sweats, nothing like that. And her symptoms are quite predictable. And then there's Mary, who's 64, and she's also fit and healthy. She does have a few things in her background. She's hypertensive, but that's well controlled. She has osteopenia. Her mother had quite severe osteoporosis, so she got a private DEXA scan, and she's an ex-smoker. Her main complaint is joint pains and fatigue, as well as some low libido. She has vaginal dryness, and she still does have some hot flushes, albeit they're not sort of debilitating to her. She feels she's missed out on MHT, and I apologize through this talk if I call it HRT, because I'm still in that era of years ago, and I'm trying to train my brain to say MHT. And she's read about the health benefits, and so she's wondering whether she wants to take it. So menopause, scope, significance, why should we be bothered about it? I suppose it's a significant biological change in midlife. A woman's risk of heart disease, osteoporosis, diabetes increases quite dramatically at the time of menopause. And at the same time, there's an increasing responsibility and stress for women. Often they're at a time where they might be carers for their parents, they're looking after kids, their career might be changing. And so there are these demands as well that are changing. As I've sort of alluded to, there's also quite a lot of misinformation and information available. I think even as health professionals, we discuss how it's really tricky to know, particularly when doctors and MDs are speaking about various levels of evidence and what's right and wrong. So it can be a real minefield. And I feel like that's really amplified in the last sort of year or two. And accessing care can be challenging. Like these often a menopause consult, like in VVSC and in GP land, a menopause consult for us would probably be about 45 minutes. And so women often, they might have already come into the GP and said, oh, I want to talk about this. And by the way, can I just get a test for perimenopause? So it's hopefully today as well, we can sort of share how we frame a consultation and prepare for that and give some sort of structure to that to make things flow a bit easier. So this is just back to some basics, I suppose. So the terms on the left, and don't worry too much about the table. I know it's a small writing, and so it's not there for people to sort of pore over. Um, Essentially, menopause is a retrospective diagnosis, if you like, and you're saying, okay, it has been 12 months since your last period. You are now menopause. You've now gone through menopause, and following that, you're postmenopausal. Um, Perimenopause is that transition towards your last period. And we're recognizing now that 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 is possibly longer, not possibly, it is longer than we're currently giving criteria to. So that table on the right-hand side there shows what's called the straw criteria. And to be technically to be perimenopausal as per the straw criteria, a cycle needs to be more than 7 days late, and more than two consecutive or two cycles in a sort of several month period. And we actually now think, and sort of the AMS, which is the Australasian Menopause Society, which holds a huge amount of resources for GPs and healthcare practitioners, they're also recognizing, and there's some talk there about how actually perimenopause is earlier and do we need to change this. So there's definitely questions about that, and we'll go more into that later, and what to do with women who are frequently coming with symptoms and questions about perimenopause, but who are still having regular periods. So this is a graph that I often show women. So for a menopause consultation, I'll often say, okay, we need to have some time. So if a woman would come in to me in GP and say, oh, I'd quite like to talk about menopause, please, I'd say, great. Sounds like a great time to stop, pause, look at your overall health and talk about symptoms. And so before, sort of after gathering some information, we'll sort of show this graph because I really like what it shows with the hormones. So if you look at premenopause, where you've got estrogen and progesterone, and often I say to women, don't worry about what they mean. It's your hormones and it's the patterns. You've got a fairly predictable cycle going on. So obviously not every woman fits this, but you've got sort of your rise in progesterone, then you drop your period, and it comes around every month. And you might have symptoms before that, but you generally know where you are. If you flip over to postmenopause, and we'll come back to peri in a minute, these lines of estrogen and progesterone are flat. They're low. The ovaries have said, no more, we're done, we're shut. And so there is no more hormone activity from estrogen and progesterone. And so generally things are quite stable. And there is a thought, and it's not the same for every woman, but there's a thought that the body might adapt following that kind of transition and that fluctuation. So if we look at perimenopause, we've got this state of complete disarray where, you could just squiggle some lines over there and it's anybody's guess. So progesterone is sort of lacking. We're not ovulating every cycle. You could ovulate twice in a month in perimenopause. And so the endometrial lining can become unstable or dysfunctional. You've got these surges and these dumps of estrogen that can give really quite sort of vivid symptoms to women. So these huge upticks in estrogen, for example, might make a woman say, and often it's actually when I explain this, they go, whoa, yeah, like I had breast tenderness, I had some palpitations, I got really jittery and anxious. And of course, and I don't think I need to sort of fully explain this, of course, there's other causes for palpitations and we've got to make sure we're excluding anything more sinister, but I don't think I need to be. I think GPs are very good at that. So I suppose the point that I sort of make to women here is that it's this fluctuation that actually often gives you just fairly rotten symptoms. And sometimes it's the real rough time. And this time frame or period really, really varies. And I think if you get anything from this presentation, it's that actually every woman is so individual in their perimenopause and in their menopause. And so it's really conveying that to them as well. So if we look at Olivia, I sort of popped her there in that, and she could even be shimmied along slightly perhaps, but I think she's probably a sort of pre-menopause, maybe early perimenopause. And again, we'll come back to what we do about Olivia and how we approach that soon. Alison is classic. She's in the middle of the transition storm. Everything's haywire. 1 week she feels good and she thinks she's going crazy, and it's fine. And then the next week she might have terrible sleep and terrible anxiety, achy joint pains, and sometimes explaining that to women can be very validating. And they go, okay, I see what's going on now, and it can be very helpful. And then Mary's along the line. So whole variety of symptoms, very variable, very individual. Again, I often explain to women that the sort of role of estrogen is throughout the body. It's everywhere. It's in your joints. It's in your skin. It's sort of obviously in your reproductive tract, your vagina. It's sort of I like to call it the kind of conductor of the orchestra in your brain, because it has that knock-on effect with serotonin and dopamine and all those sorts of things. But also reminding women that it's not just hormones. Like, if you don't sleep at night, and sleep is just so vital, particularly in midlife, you're going to feel fatigued, you're going to feel irritable. So it's sort of, it's all interconnected. And some of the symptoms are earlier and some of them are later. And I guess, again, it's very individual, but generally mental health symptoms tend to come earlier. So, and that's, is that crossover with that early perimenopause. Okay, so diagnosis. Do you test? What do you say to Olivia, who says, I want my hormones tested, please? I usually explain sort of that it is a clinical diagnosis. Menopause is normal after the age of 45. So the average age in Australia is 51, but anyone over the age of 45 whose periods stop and has menopausal symptoms, and you can say they're menopausal, it's normal, and there is no need to confirm that with a blood test. Early menopause is probably a different talk, but it definitely needs workup. So early menopause and then POI, which is premature ovarian insufficiency, is where a woman will go through. Early menopause will be 40 to 45 and POI is under 40. And then don't forget those women who have had a surgical menopause or a medically induced menopause. So that needs evaluation. So for example, if a woman comes in age 40, she has got classical sort of menopausal symptoms, she might have a Mirena, and so she may be amenorrheic, or she might say, I don't have any, my periods have stopped. That's when I would do an FSH. And there's a link from the European guidelines, which are what is endorsed by Australia, for workup and investigation. And they're really clear. They basically say in someone who is under the age of 45, who has oligo, which is sort of irregular, or amenorrhea, an FSH above 25 times 1, not 2 anymore, will confirm early menopause. And those women need a workup to say, okay, you're at more risk. So we know that women from early menopause are at more risk of cardiovascular disease, dementia, osteoporosis. So they need that workup to sort of check DIXA, check other autoimmune conditions, but actually often it's familial. So if you ask them, when was your mum, when did your mum go through menopause, or your sister, they'll often list that it was like 30s, 40s. And obviously rule out other causes. So in Mary, her symptoms shouldn't be new. If someone came in at 65 and said, oh no, I can't remember menopause, but now I've got these hot flushes, I think we're looking at something different that's not menopause. So for everyone, I think it's really good to talk about lifestyle advice. And again, I am definitely preaching to the converted, I'm sure, here in primary care, and we're all pretty good at this. I think as well, framing menopause is not necessarily a negative thing. I think obviously you've got to pick your patient for that. And if someone comes in who's really struggling, I'm not going to say, oh, look on the bright side, it's a great time. But hopefully it's that therapeutic relationship, that, you know, it's a time to pause, reset, think about your longevity, think about, you know, what you do now in terms of exercise and strength and balance does really impact you when you're 60 and 70, and talk about risks. So heart disease, we know that we're very biased to men for heart disease. So, you know, lots of women sort of go, oh yeah, blood pressure and cholesterol. Oh yeah, okay. So it's a real time to go, okay, let's stop, sort of sort this out, if you like, and make a plan going forward. Um, Other things, I think we sort of know all these things. Weight gain is huge in terms of a huge issue for women. It's fast, and I think and so I often explain that, you know, muscle mass is dropping from estrogen dropping, metabolic rate is going down, and so weight can come on quickly. And again, that validation makes women feel like they're not going crazy, and they're not sort of, you know, and also saying it does plateau, but there's still ways to manage that. And whether that's, you know, increasing protein, increasing fiber, looking at that makeup of carbs and what we eat, and not also forgetting calcium, and ensuring they've got adequate calcium intake. So MHT is still the gold standard. There's still a hangover effect from the Women's Health Initiative studies that were published with very bad press, but we've actually also got a huge amount of information to look back, and so it's been re-examined. So we do know quite a lot about safety profiles of MHT, and it is indicated for moderate to severe vasomotor symptoms, genitourinary symptoms, and osteoporosis prevention. So that's particularly in those women who are early menopause as well, to make sure that they don't develop osteoporosis. Your best candidates are under 60 and within 10 years of that menopause window, but that really is not. I mean, I think I remember it actually seem that long ago that I would see someone and go, oh, hang on, 60, maybe it's time to stop. That attitude has gone now, I think, and it's very much an individual. I think I feel like I'm going to say this throughout the whole talk. So no absolute limit how long it can be used for, and it's just ascertaining someone's risk, essentially. So you've got different options. The way I explain it to women is I sort of often hold both my hands out, but I say you need estrogen, which is going to help many of your symptoms. And if you've got a womb, then you need progesterone to protect your womb. Because if you don't use a progesterone, then that womb lining will thicken, and then it can change, and it can become hyperplastic or change to cancerous cells. So really important to have both, unless they've had a hysterectomy. And at the moment, I know there's discussion on social media, but really progesterone's role is for protection of the womb, rather than sort of lots of added other benefits just now. You get oral options for estrogen, you get transdermal, so gel, patch. Oral, I don't feel like I prescribe oral very often at all anymore. It does carry a slightly higher DVT risk. So obviously in patients who have any VTE risks, so they've had a DVT before, they might have migraines with aura, they might be higher cardiovascular risk, you're just not going to use oral estrogen. I'd say the group of women who like oral estrogen might be those who are younger, who really want the convenience of taking a tablet. And they may actually want the pill. So the pill is still sort of MHT. And some women really don't want that, but it can suit some of those early perimenopause women who might need contraception. They may need some period control, and it's just convenient. But often I'll say to women, if they're going on oral estrogen, look, I think as time goes on, it makes sense for you to change to transdermal. And younger women often need higher doses of estrogen. So there is really no one size fits all, because in terms of absorption of transdermal estrogen, there is a tenfold discrepancy in how women absorb it. The other thing to just bear in mind is progestogen intolerance. And this is something I sort of became a lot more aware of when I was getting in more involved in women's health and menopause itself. But about 1 in 10 women will be progestogen intolerant. So I will always ask, have you had the pill when you were younger? What was it like? And women will say, oh no, mood went crazy. And that just might make you go, okay, you may have a sort of progestogen. And when I'm talking about progestogen, I mean synthetic progestogens that are in the pill or in sort of MHT, but as opposed to micronized progesterone or prometrium, which is body identical. And body identical progesterone is far better tolerated. And so that tends to guide you. Also, body identical progesterone, prometrium is generally considered safer as well than the other synthetic progestogens. So genitourinary symptoms, very common, very under discussed, and really quite effective to treat. I think there was a statistic that said that 6% of women are treated, and it affects about 70% of women. Helen might correct me if I've got that wrong. So it's quite straightforward to use local estrogen therapy, so Ovestin, cream, pessaries, really safe, effective, safe in women who've had sort of breast cancer, and long-term use is fine, and really good for urinary symptoms. Often women go, oh, hang on, I don't have any vaginal symptoms, or they just normalize that getting up twice overnight to wee is okay. And so Ovestin can be quite a game changer for that. And for some, the cream is better. They can put it on the outside if they've got some dryness, and they actually only need it in the lower third of the vagina, so they do not need to be sort of getting all the way up there. Prasterone is quite new, Intrarosa, that is a pessary. It's a DHEA and it's converted to estrogen. It's daily at night time again. That I don't use that too much, but it can be useful in women who don't tolerate Ovestin. So some women who've had recurrent thrush, they start Ovestin and then the irritation comes back and they just get thrush. And although thrush is not that common postmenopausally or menopausally, it still can be triggered by estrogen. So that's a good group you could use that in. And then obviously just consider other diagnoses. If things are not improving, have a look. Fezolinetant or Veoza is also a new-ish oral non-hormonal. It's a sort of blocker of the KNDy neuron in the hypothalamus. And it's quite effective for hot flushes, but you do need your LFTs monitored. I did know how much this was. I want to say it's about 50 or 60 a month, but I can look that up. I don't use it very much, but some of the breast surgeons have said they'll use it off-label after trying alternatives in those who've had breast cancer. And testosterone, a big one, and lots of stuff online about testosterone. It is licensed, and this is where I tend to stay in the lane. It is licensed for low libido in postmenopausal women. And it has been shown to be beneficial. So it's there's other claims online, or I say online, there's other claims about vitality and bone health and dementia prevention, and people are sort of picking at different studies to show this. But at the moment, certainly the AMS guidance is that there is no robust evidence for any of that just now, and studies are ongoing. You need to monitor it, so you need to check the testosterone prior, just to make sure it's in the female range, and you're looking for, if it's low normal, then you may end up getting more benefit than if it's sort of on the high end of normal, and then it needs checked at 1 month, then 6 monthly going forward. It's something that's private, costs about $100 for 3 months. You use it as a cream on the outer thigh, and you can get some side effects, so acne, hair loss, greasy hair, like voice changes and clitoral enlargement are rare, but they can be irreversible. And also libido and sexual dysfunction is multifactorial. There was an interesting article published a few weeks ago, or a couple of weeks ago, called the Midlife Women's Year Study. There is a link at the end, just to talk about how actually perimenopausal women, their libido, compared to the testosterone levels, their libido is just hugely multifactorial, often related to body image, all these other things. So it's just sort of addressing that with the patient. I'm sort of aware of time here, so I'm going to zoom along. GLP-1 agonists, take-home message really from that is just to bear in mind that it reduces the absorption of oral MHT. This was particularly with Mounjaro. So it's just counselling potentially patient about bleeding, and and then thinking about either topping them up. There's a link from the British Menopause Society, just looking at that, and I don't want to spend too long on it just with time. So breast cancer risk is a big one. I feel like that's probably one of the biggest things that comes up for us in clinic. And it's quite nuanced. I think it's all very well saying, oh, MHT doesn't increase your risk, but then when you've got a patient sitting in front of you who sort of you want to counsel properly. So if we go back to Alison, way at the beginning, her mother and her sister had breast cancer, and she was BI-RAD C. She had no other significant risk factors. So she wasn't obese, she exercised, she didn't smoke. And with her, I think it's really important, sort of when women come in and I sort of have a bit of a sort of flag of, oh, you're possibly higher than average breast cancer risk. I think the I Prevent risk tool through Peter Mac is really, really beneficial. It takes a while. So we do need to sort of take the time with the patient or ask them to do it before, but it will give them a really good infographic of their risk compared to population. And then it will stratify them into sort of your average risk, you are moderate, so sort of up to double the population risk, or you are 3 to 4 to 5 times population risk. And on that framework, and everybody is sort of different with their comfort levels of prescribing, but on that framework, I generally sort of, if someone's at moderately increased risk, which Alison is, MHT is still an option, and it's sort of counselling her about her individualised screening for breast cancer, looking at other risk factors, maybe duration of HRT, like is she going to go on it for 20 years, or actually would 6 years be better? But obviously it depends on her symptoms. And for high risk women, the general consensus is individualized screening regime, consider alternatives before MHT. So I also show this to women, and I think it's really good. And sorry, I know it's probably quite small writing, but this is an excerpt from the NICE guidelines, understanding the risk of breast cancer. So this is per 1,000 women aged 50 to 59 in the UK. 23 will just get breast cancer because they're female, an extra 4 with HRT combined, and that's actually the sort of older, more synthetic HRT, so it's possibly lower than that. And just looking at even obesity, smoking, alcohol, and reducing your risk with exercise. So Alison, so I have a big chat. This is the 45-minute consultation. I meant to mention earlier, but I think another thing that's really helpful before a consultation is to give them a menopause symptom score. It's the table with all their symptoms, and it's really good to document. Goes in their notes. You can do it again at 3 or 6 months, and again, give it beforehand, or the I Prevent as well, if you think there's a bit of a flag, and get them back with the information, maybe with their cholesterol, so you get an overall picture. So she decides to go for MHT. Really need to talk about contraception with her, sort of for at least a couple of years, or really until the age of 50, 51, when she's sort of still, because we don't quite know when she's going to hit full menopause. She needs progesterone, as we said, because she's got a womb. Irregular bleeding is normal with HRT. Like we're sort of, or sorry, I've slipped into my HRT rather than MHT. So it's normal for the first 3 to 6 months, and it tends to get better over that time. But if beyond 6 months, women are still bleeding out of sync on that cyclical regime, or irregularly in any other way, then it needs investigation. So it needs an ultrasound and possibly a biopsy. Mirena is a good option. It's only 5 years rather than 8, and cyclical regime really until 51. So that's where you're doing sort of 2 weeks of, say, prometrium, but obviously estrogen every day. So Olivia, this is a bit of a grey area, like I said before. PMDD is actually more common at this stage, and I find it really helpful to talk to women and share that uncertainty and say, look, this is this graph, and you could be early perimenopause. We don't necessarily have criteria for that at the moment, but we know that there are changes, and those are mood changes. But actually PMDD is really common, and this is what happens in PMDD. And often women are happy to accept that sort of uncertainty. And actually the treatment is often sort of the same. So the only difference really is with PMDD, the aim is to suppress the cycle. Don't have to, but generally first line is the pill. And one of the newer generation pills like Zoli, Nextstellis, Yasmin, because the estrogen in those pills crosses the blood-brain barrier better, and so they'll get better symptom control. If you give someone with PMDD a low estrogen pill, it will paradoxically worsen their symptoms. And then other options, add an SSRI. You can switch to MHT if you use MHT at a high enough dose. So if you give them around 100 of estrogen, 100 patch of estrogen, you will probably suppress ovulation as well. But obviously you've got to titrate to get there, and knowing that women absorb it differently. There is some evidence for B6, magnesium, and chasteberry as well. And there's a good guideline. Again, I've got a resource at the end for that. And Mary, 64, I think it's gathering all the information. So it's ascertaining her cardiovascular risk. Is she low to medium risk? And I would put that into a calculator. We know that if we start someone on MHT who is high cardiovascular risk, we can trigger events. So it's important to just go, okay, great, you're not high risk. So other tools like the iPrevent for her. CogD risk is the dementia sort of risk score, which I think is useful for patients to do. One, they can do it at home, and it just sort of, I think it's good for them to be aware of different risk factors. She's probably not going to get the bone health benefit. She might, but it's probably earlier on in the piece for MHT. And I'm not sure we've got strong evidence either way for that. And with someone 64, without a doubt, in my mind, I'd be transdermal, estrogen only. I would not be giving her oral estrogen, and maybe other clinicians would. And I'd also be giving her prometrium. So because we're giving her the safest MHT we can. Think about vaginal estrogen and consider testosterone. Like, as I say, it's licensed, she may get some benefit. And just that annual review of risk versus benefit. So in anyone who starts MHT, I say, let's see you at 3 months. It's incredible how many women come back, many of whom are extremely astute and intelligent, and who say, oh no, I've just been rubbing the gel in my forearm, or I didn't bother taking the progesterone, I didn't like it, or I've only been taking one, or so I think probably the initial consult is often quite overwhelming, or maybe that's feedback that I need to be clearer to women, I'm not sure, but I do find that it's a really good time to stop and just check. So 3 months, and then an annual review going forward, because lots of women say, when do I stop this? And you go, well, every year you have a look at it and go, do you want to wean off? And do you want to see how you go without it? What's that lady's decision, essentially. So our menopause clinic, or the VVSC menopause clinic, basically is hopefully there to support GPs. We are passionate about general practice and primary care, and we would love to have co-consults. We love it when we have co-consults with nurse practitioners and GPs, and we run on time. I thought it was quite useful to say that, or we very much will for co-consults, because we know your time is very precious. But we also see direct referrals, so we're happy for women to book in if they want to do it at home, and that's preferable for everybody. An initial consult is 45 minutes. We will send out a survey and the menopause symptom score before, so we've got all that information. If GPs or practitioners want to send a referral letter, fantastic. Like, we've had excellent referral letters in, which have been really helpful. But equally, if it's just the booking link, then that's also okay. And really happy for sooner reviews or discussions or emails or whatever. And these are the resources which I can try and ask Morgan or Nicole to sort of get access to, just because there's some good links, but mainly the AMS and some of that PMDD guidance can be really useful. And thank you for listening.
Thank you very much. We'll open up to questions. So I'm not sure, Nikki, if your preference is just questions in the chat, or if anyone wants to unmute and just ask away.
Yeah, either Helen, do you want to read? Is there been anything in the chat that you want to read out, Helen, or is there anyone that wants to talk?
So I was just putting some stuff in the chat about, we had a really good question about the bone benefit of MHT, and I've just popped it up in the chat. There's quite good evidence that they have updated in the practitioner's toolkit for menopause management, which is a great resource. I'll pop a link up for that as well. But I've just popped up in the chat that the recommendations in that toolkit, prescribing MHT solely for bone health for women aged under 65 with a T-score of -1.8 or less, it will likely reduce fractures in that cohort who are asymptomatic and postmenopausal, and benefits outweigh risk. I don't believe we have the studies in older women at the moment currently.
That Nina said, what would you make? What would make you titrate prometrium if biopsy normal on ultrasound? I see some people on 200 and wonder what the indication is. That question came up recently, actually, and it is difficult, and there's actually no clear and concise guidance. And interestingly, the AMS has acknowledged that in the last week or two, that we need more clear and concise guidelines about prometrium. And Helen, it'd be interesting in your take on it. I tend to put 100 for continuous for prometrium, but once we're getting up to sort of 75, maybe 100 milligrams, so a 100 milligram patch, I would sort of talk about 200, maybe taking into account there are other risk factors for endometrial cancer. But Helen, what's your...
I will always go up at 100, and I've had variable sort of consensus from specialists about whether they increase to 200 at 75 milligrams or not. I think if someone's BMI is elevated, I would increase to 200, or sometimes just using off-label vaginal progestogens for those patients. It's effectively double the dose and absorbed vaginally. The other one to be really aware of is those patients on GLP-1 inhibitors. There is some evidence about increased postmenopausal bleeding in patients on tirzepatide, Mounjaro. We don't really know where the space is with Wegovy, Ozempic as yet. They're seeing, as I'm sure everyone is aware, some unplanned pregnancies as fertility improves with patients, and I think it's an evolving area, but there are some concerns about how the progestogen's being absorbed while patients are on those medications. So I would err on the side of going to higher dose at a lower threshold with them. And the advice currently coming out of the UK is that if you up-titrate a dose, then doubling the progestogen dose for 4 weeks while the patient adjusts to that dose.
60-year-old with a history of stroke due to PDA has been prescribed estrogen cream for vaginal dryness. Is it safe to have estrogen cream for her? My answer would be yes. Yes. Vaginal PD, yes. Helen? Yes?
Yes, absolutely.
Patient taking Femiston, improving all other perimenopausal symptoms in the last 3 months, but mood getting more snappy. Any suggestions is the scenario which I faced. Yeah, interesting. So Femiston is oral estrogen. You can get it in a 1 milligram or a 2 milligram preparation, and a synthetic progestogen. So I think I'd be looking at either going, do you increase it to 2 milligrams if she's on 1? Or saying, have you got progestogen intolerance? Was this moodiness something that has come on since you started it? And what do they want to do? So it might just be changing. Sometimes there's no rhyme or reason. If they're like, some people do well on gel. There's sometimes people who switch to patches, which some people prefer for mental health, because you sort of more steady state. I like it's sometimes just switching and saying, okay, will that work any better?
And again, I might, while we're talking about topical estrogen in the chat, with obviously a proviso from the patient's oncologist, many oncologists will allow women to use Vagifem, which is lower dose. They have the dose some time ago, but we always, write to the oncologist and request that they give their blessing for that. So that's also something that can really improve quality of life for some of those women.
How do you counsel how to use the gel? I point to the hand sanitizer because it's sitting on my desk. Although I should, often I've had a fake estrogel as well. But I say push the pump all the way down into the palm of your hand. you're going for surface area, not rubbing it in. And you're going from wrist to shoulder and covering the arm. And I often say women tend to sort of, it needs to dry for 3 or 4 minutes. And so if you're someone that sort of does all your creams and potions and lotions at night, and you can do that, great. Often some women will say, oh no, I just jump into bed, a gel's not going to be for me. And the only other thing I would say about the gel that I sort of learnt, I always start on 1 pump, even though I think, oh gosh, you're perimenopausal, you're probably going to need 2. If you start on 1, if you've got someone who's quite estrogen sensitive, they will get nauseated, headaches, feel terrible on 2 pumps straight away, and you might put them off it for life. So I say go on to 1, and you can go up after a week or 2 weeks, and even slower for those women who've had endometriosis. So they're a sort of separate group that we've got to be a bit careful of. Those and the women with fibroids. Is that you agree with that, Helen?
Yes, and I have just put in that little picture because the one fun fact we learned at the menopause conference was for those women who have cats and they let them lick the gel, it can actually cause bone marrow depression. So just be mindful of that. With I now ask my patients if they have a cat.
I don't actually. I should start doing that. Can you describe how you advise to take cyclical? So cyclical is, yes, so I generally say to women, we are going to take over your cycles for you type thing. So we say, I want you to pick a date. So women get quite confused and they think, oh, I better take, better wait for my period. I say pick a date, and let's say the 1st of the month, which usually suits most people. And on the 1st of every month, you take 2 tablets of progesterone at night time until the 14th, and then you stop it. And I say, because we're doing this, you're going to have irregular bleeding, and most women do not get overly bothered by that, and it's not too disruptive. But your body will catch up, and then over the 3 months it will start normalizing, and you should bleed when that progesterone stops. And that's why it's really important to see them at 3 months, because as I say, women, it's such an overload that they go, oh, I've just been taking 1, or I didn't get my period, so I didn't take progesterone. There are other ways to take it cyclically, and you can shift around the regime a bit, but it's off label. And yeah, it's probably a different discussion. All the slides. So yes, you can try them to continuous after 12 months, absolutely. But in women under 51, you may find that they just start bleeding. And although the patient might not be too bothered about that, as a practitioner, we're going to be thinking, oh gosh, where are you bleeding from? And we don't know what's going on. So I usually warn them that they're likely to need continuous until 51. But as I say, you could try them. Yeah. Is there a creatine supplement brand you recommend? No. Helen, do you have any creatine?
Look, there's not sort of the menopause societies don't routinely recommend creatine, but many doctors who work in the space probably take it themselves. I can't give you a sort of trial evidence comparison of brand. So I don't ordinarily recommend brands to patients if I don't have sort of good hard evidence behind it. If they really pin me down, I will tell them what I take, but yeah, I can't really give you a specific brand to recommend for that. The only other thing I would say that is extremely confusing, and I have begged the rep for Bessons on many occasions if they can change it, is the guidance for continual hormone therapy. So it says in the product information 25 out of 28 days in a cycle, and it's nonsensical because those women are not cycling. They will not change that product information because that was done on the trial and how the TGA gave approval. The reason for that 3 days off is you get suppression of vascular endothelial growth factors. So you have increased bleeding if you have it every single day, which some women who are very progesterone intolerant will choose to do regardless. But it doesn't have to be 28 days, but if they're struggling with that regime, they can sort of off-label have 3 or 4 days off per month. But that is why the information talks about a cycle when those women are not having a cycle.
Thank you very much for your time to both presenters. I mean, I learned a lot to be honest. A few more. We might do one last question if that's all right. It's just coming from Janelle, and then I'll wrap up.
Is there anything to consider in switching from synthetic oral to transdermal? No, I think I warned them that it might be a bit of a bump because it's so variable on how they might absorb it. And, if you're going from 1 milligram and they've still got symptoms, you're probably not going to start them on 25 of a patch, if that's sort of what the sort of question is. And then I would just counsel that we need to go up. But, too much estrogen does not feel nice either. Like when women go crazy with gel and patches, you get estrogen excess, which gives you headache and bloating and breast tenderness, and that's not fun. So it's just being aware of that too.
And then next year, it would be lovely to have everyone back or tell anyone who you think might find upcoming topics interesting around common workups for FBEs, advanced care planning, kind of around ophthalmology and general practice. But if there's any sessions you'd like, please let us know, and it'd be very helpful. Thanks very much, everybody.
Thanks, everyone.
Thank you. Have a good evening.